during the case presentation, I can just very briefly repeat that we have on the table, you are in Copenhagen. It's a Copenhagen team. My name is Gintas Bielauskas. We have an excellent team of fellows and nurses. The patient, who is a female, 83 or 82, yeah, she is 83, with atrial fibrillation, severe aortic stenosis, and no other major comorbidity except for moderately reduced renal function. Okay, we were also trying to show some screenshots here, which are from CT planning, which we were using to judge the size of the valve, of the anatomy, the calcification, the angles, which we will use to deploy the valve. You can see on the top row here, this is annulus and LVOT measurements. They are big, in the range of 90-94 for perimeter. We have sufficient size of sinotubular junction, around 29, sinusoidal valsalva, on average more than 34. We have sufficient height of both coronaries, so we don't expect any coronary issues. We have severe calcification of aortic valve, as shown in this middle panel here. We have calculated angulations from which we will deploy the valve. We have selected Evolut 34 as a valve for this large anatomy. We could have also selected Sapien. We have that on the shelf as well. Both would fit, but in this case, we will use Evolut. We also, of course, always judge anatomy or look at the iliacs and aortic arch, whether or not we will cross it difficult or easy. So this aortic arch should hopefully be feasible. It's a little bit acute, but not too acute. We hope not too calcified. We hope the device will traverse it pretty easily. We also will attempt to use a sentinel due to the severely calcified valve. We know there's some controversy and evidence, but we tend to select patients, selectively use that sentinel device, not in all our cases, but in some of them. And severely calcified valve, bicuspid anatomy, valve in valve, those would be among the potential indications. So this we qualify as severely calcified aortic valve with a big calcium burden, and that's the reason we will try to use it. Anatomy seems favorable, so we incline to use it. That's our plan. Now behind my back, my colleague Ronnie, he is already, I can see, accessed the right radial and contralateral vein and artery. So while Ronnie is going to continue for the main access, we do it ultrasound guided. I will scrub in myself and will join you by the table in just a couple of minutes. Meanwhile, Ronnie, you can, if your microphone is working, you can also tell what you do. You can only hear what I'm saying, not Ronnie. Is that correct? Okay, so that at the moment, then I can continue, guiding you through the case. Let me scrub in. I have to scrub in because I was willing to show you some of those CT scans. That was the reason I wasn't scrubbed in. And as of right now, Ronnie is set already. We have right radial access, and we have also the access on the left side in the femoral vein and left common femoral artery. So that's been done using ultrasound guidance. That's our standard these days. We use ultrasound. I believe most sites do it like that. Ultrasound guided punctures. They are usually precise and less risky. We also integrate knowledge from our CT scan. So we know, for example, if you see the angio screen, you can see there's a prosthetic joint on the right side of the patient. We know that we want to access the vessel, the right common femoral, approximately in the middle of that artificial femoral head. So Ronnie just did a very brief fluoroscopy to mark fluoroscopically that location, and he also then integrates the echo images together with these angiographic images to judge the proper position. So you might be a bit on the medial side, Ronnie, yeah? Your artery is a bit on the lateral. Yeah, so, okay. And then let me just join Ronnie by the table. Basically, with ultrasound-guided approach, it's very rare to have an issue while puncturing. It's possible, of course. Typically, the risk factors for, access site complications, they would be obesity, for example. This patient has a normal BMI, so we don't foresee any major problem. Otherwise, each time the distance is more from the skin surface to the artery, you may expect, things like buckling of the wire, kinking or something, looping. So it's important. To have a straight puncture, not to manipulate too much with the needle while you poke there under the skin, trying to reach the vessel in the optimal position. Then when it comes to pre-closure, so we use both suture-based devices and plug-based devices, and our preferred strategy is to use a combination of them. So what we intend to do, and this is kind of our standard at the moment, is one Pro style, which is a suture-based device, in combination with an angioseal by the end of the procedure. Sometimes we add a second Pro style, depending what is the result after the first one is closed. And that is something that we will attempt to do. Also, another thing actually, which is a benefit of ultrasound guided puncture in the groin, that you can normally give local anesthetic very precisely, because you see where your needle is coming, and even after you access the vessel and you have a wire in the vessel, it is easy to precisely identify the location where this wire enters the vessel, and then it's easy to add additional local anesthesia based on that. That's what he's doing right now. So we have access. If we want to document the needle height, we need to go a little bit RAO here. I can take this. Let's take a look. So this is just for us to understand where did we enter the vessel. So we entered, just above the middle. Just above the middle of the vessel. This is more or less as we wanted. Slightly, maybe a centimeter or so higher than we originally anticipated, but that should still be fine. You gave enough local, yeah? Good. So it is important, if we anticipate, of course, on the right side here, even for the TAVI sheath and for the TAVI device itself, it's important to make a small cut on the skin surface, so that those bigger devices that are up to 20 French in size, they can come in easily. We pre-dilate here with a 6 French sheet, and now our next step will be a single Pro style, which is on its way into the patient body. Now here it's important not to kink a wire or anything. Like if the patient would have a bigger distance from the skin surface to the artery, you should actually use a long wire for this. Here we use just a short one because BMI is normal, as I mentioned before. So we don't foresee any problem. We have to have a nice back bleed from the Pro style to be sure that we are sufficiently in. Yeah, this seems to be okay. You pull back a bit, yeah, and then it's either based on your tactile feeling, or sometimes you can also do some fluoroscopy to judge the correct direction. Okay, shoot. Here, of course, we're slightly we don't fully see due to this prosthetic joint, but sometimes if there wasn't prosthetic joint, you can pretty clearly see the direction of your Pro style, and you want it not to be tilted or kinked or rotated. You want it to be in a straight line so that the needles catch properly. You see there's the needles. For those who don't know the device, there are a couple of needles that shoot in, and that way deliver a suture through the vessel wall. Okay, so I hold the Pro style for you, Ronnie. Just like remove the slack on both of them. Yeah, you take both of them. We remove the slack like this. Yeah, and okay, and there we take a wire along at like a J wire right now. Yeah. So basically, now our next steps will be the following. We give heparin. So usually heparin, yes, Birgit? Yeah. Yeah, faint. So normally we give like 100 units. Ronnie, maybe you can handle that tip because I cannot open it up. Or we may need a loader actually. Can we get a loader? Because, yeah. So after the Pro style is placed, of course, we need a wire back, and we got a wire without a loader, so it's a bit tricky here to come back into it in this particular situation, but now we got a loader, so it will come back. Wire comes in, then we will use slightly bigger sheet because ProStyle itself is slightly more than 8 French, so we will use a 9 French sheet. That's okay, that's enough. Loader is there. Yeah. Our patient, by the way, is in full local anesthesia. You can hear in the background maybe our nurse, Birgit, she's talking to the patient and letting the patient know what we're doing. The patient has no sedation. It's a complete local anesthesia she has, similar to a PCI procedure. So now we have access in all places we want to have access. We have the right and left femorals. We have a left femoral vein, femoral arteries, left and right, left femoral vein. We go up now using AL catheter, L1 catheter that is, across the aortic arch, and we will park it where brachiocephalic trunk is, approximately there. We will use this catheter as a guide while we are placing a sentinel. But before we do sentinel, we will also take JY. No, wait a minute. JY with a loader. We will still put pigtail. Before we put pigtail, we will also put a longer sheet on the left side, which we will use for continuous blood pressure monitoring. So you start. So first we come up with a wire. We will next put a slightly longer sheet, which will ensure easier manipulation with a pigtail. Here, maybe it's not even that necessary, this longer sheet, but like in some cases with a bit more tortuous vessels, it's actually a handy tool, but we kind of routinely do it anyway, also here. We will connect blood pressure to this sheet so that we can monitor it continuously throughout the case. So aortic pressure is here, and then the 6 French pigtail will come through this sheet and also will be positioned in the ascending aorta. And it will also help us guide the deployment of the sentinel device. So the 6 French pigtail is coming up right now. All right, so we should see it crossing the arch at the moment. And we won't go down to the valve yet. We will just park it at the level slightly deeper, maybe Ronnie, slightly deeper. Let's go forward. Yeah, a bit more, even more, just closer across the brachiocephalic trunk there. That's okay. All right, that's it. We can connect contrast effect. So I'm just told that the valve is already prepared, the TAVI valve, so we can actually do a fluoro check of the valve just to ensure that we have no issues. It's recommended to check Evolut valve. Yeah, so JY first. So we will check the valve in a second, just to ensure that it's properly loaded. That's a standard procedure with Evolut valve. We have to make sure that there's no too much enfolding, that there's no both retainer tabs are correctly positioned. So we do that here in just 1 minute. While we wait for valve to come to it, we will also put a longer sheet inside of the left femoral vein. It's also a 6 French sheet. We will have it inside just in case there would be an AV block, so we have easier situation in terms of careful running the wire. Let's try to go. It wants to take some branch there, that wire, yeah? Yeah, so we want to, like this. That's it. Okay, now you go up. And now let me walk the delays out. You hold the sheet. So what we have here is a 6 French sheet, which is slightly longer. It should facilitate putting the RV pacemaker if we have to put it. But normally we anticipate that we will pace actually on this wire in the venous sheet. Do you have it, Snile? It's, yeah. We'll put this J wire back into casing. It's actually, as you see on the fluoroscopy screen, the wire sticks a bit out from the longer sheet left femoral vein. And this wire we will use to deliver pacing, because one option is to pace, as we know, on the RV. Another option is to paste on the LV wire, but then you need a second source, a second contact, which is either at the skin level or it can also easily be a wire inside the patient. So we'll use that in this particular case, the wire. Now we're going to check the Evolut loading. So it's a fluoroscopy check. We zoom slightly up. I will zoom a bit more. And in the fluoroscopy screen, we'll immediately see the retainer tabs are perfectly loaded. They are nicely caught in the good position. There's no infalls. There's no struts that would be kinked or bent. So it's a very good load. We're happy with that. We keep the valve now waiting to be deployed. And our next step will be to flush the radial and to deliver the Sentinel device. Heparin is given. Confirmed, yes, heparin is given, so we should be all good to go. Let's check. Let's wait a minute. Let's pull. You pull back the wire, yeah? Now, Ronnie, just a little bit in. Okay, wait. Now we come back, come forward. Wait a minute. We come. So Sentinel device is a filter-based device to protect against embolization, and it's delivered on the PCI wire. It's a BMW wire that you're seeing, which is finding its way down to the ascending aorta. Let's double check that it's ascending aorta. It should be ascending aorta. Yeah, indeed, that's fine. We go a bit LAO, and wait a minute, Ronnie. So the angle in which the Sentinel is about to be deployed is LAO angle. I showed it to you based on the CT scan. One option to know the anatomy is to do some angiography in the ascending aorta, but we will not do it. We will normally we do it based on our knowledge from the CT. So Ronnie is now going forward. I'm applying a gentle railing there. In case there would be too much tortuosity, we would ask the patient for deep inspiration, for deep breath. And now, what we see here is the device sitting in the ascending aorta. Let's go slightly deeper, maybe. The black band that you see right above our catheters is a filter, a proximal filter. So we will start deploying it, and we deploy it right here, just above those catheters, because catheters are lining up at the outer aortic curvature, and that way we know where the filter should be sitting. So we will gently pull back that filter slowly up like this. So the filter should be now nicely inside of the brachiocephalic trunk. We will a little bit pull back on that pigtail and AL catheter so that they don't get entangled once we look for access inside of the left common carotid. Now you will, Gabby, pull back the wire a bit. So next step is to flex the tip of the Sentinel, and Gabi, you try to advance it. Continue a bit forward. Yeah, continue. That's promising. That's promising. Wait a minute. Let me try to see. What is it? Is it? Now we have to be sure that we are in the left common carotid and not somewhere else. So let's do a small injection here just to double check. 15-15 or 10-20. Keep it like that. Yeah, enable. No. Yeah, just to double check. Because if the wire would be in the subclavian, then of course we need to reposition it. So we'll do just a 10 cc injection. So we are indeed in the subclavia. That was my suspicion because it kind of seemed to be willing to enter the vertebral. That means we need to get closer. So Gabi, you try to get closer. Let me flex a bit. You pull back a bit more. Pull back on the wire a bit more, and re-advance. Yeah, there. No, this is the same. Let me unflex there. Yeah. This is very nice. Very nice. This is the carotid. You see, it's very close to the actual brachiocephalic trunk. So good. We have the carotid. Now, what next step, Gabi, you will hold the wire, and I'm pulling back the Sentinel system. I'm pulling back the Sentinel system just to allow it to engage the carotid. We check that we are, above outside aortic lumen. We seem to be good positioned there. And then the final step in sentinel deployment would be to deploy the distal filter, where Gabi will be holding the wire here, and I'm putting out the distal filter number 2. That's it. So we are pretty happy. Both filters are deployed. Flora, save that. Sentinel is in place. So in ideal scenario, it takes no more than 3 minutes or so, 3 to 5 minutes maybe, to deploy it. So procedure gets a little bit longer, but by much, not by a big margin. And of course, if we can hope for some kind of additional protection, then that's the reason we do it. Now, next thing, what we will do, we will try to cross aortic valve. And our favorite way, or favorite angle to do that is actually the cusp overlap projection. In this so-called cusp overlap projection, we have a tail sitting in the non-coronary cusp, and that's on the left side of the screen. Okay, and we see a calcified, a bit chunky non-coronary cusp, which opens and closes. And then we know that that's exactly next to that chunky cusp where the wire should normally find its way into the ventricle. Of course, it looks a bit challenging here, to be honest, because that chunky cusp, it seems it kind of closes the pathway from this angle to cross the valve. So Ronnie, let me try. Maybe this appears is potentially challenging based on how it looks from this particular angle. But then what we will do, we will try this wire a few times. We will try this catheter a few times. In big anatomies, sometimes it's beneficial to change to AL2, and sometimes it's also beneficial to try a more slippery wire, which would be a Terumo wire. But before we switch to any of those, we will still explore this catheter. Let's unpack AL2 maybe already, because it's pretty vertical anatomy. It's in a larger aortic root. I will also try to see how wire position looks from LAO. You know, so we seem to be a bit too close to the left carotid, not carotid, to the left main. Like the AL1, which we have currently, for me appears to be slightly too curvy. We need a bit of a bigger curve, like less direction towards the left main and more direction towards the non. Let's take AL2, because I think that should hopefully give us a more beneficial shape. So we keep the wire, keep the wire, and we take AL2 catheter just for hopefully better shape of it. Yeah, and then we'll try to see again. How does that do? I go back to cusp overlap projection here. And I think if we would still have struggle here, we might take Terumo wire as our next wire. So now we're approaching with AL2. We'll see if we have any better luck with that one. Yeah, so this one is certainly more vertically positioned. Let's see if this allows us to steer it better. Yeah, the chunky non-coronary cusp. I can do even a short cine here. Do not enable, just to show you. So on the screen, you can see this chunky non-coronary cusp is almost on top of the other cusp, kind of preventing the wire to slip in. I hope we will still find its way. Because there should be a commissure next to it somewhere. It's not just one spot. Let's hope that we will find its way. If this wire struggles, there we go. Well, that would be the place, but it just doesn't want to cross it. Now, before I attempt any further steps, let me also check once from LAO. How does it look like? Yeah, here we seem to be good. In LAO, it's much better this time. So it's okay. It's middle of the valve, so we are not in any kind of a strange angle. We're in a good angle. So it's just a matter of finding its way, really. I think think we probably need to ask for a Terumo wire here too, because it's probably, let's take a Terumo wire, because I hope it looks like the shape of the bulky shape of the leaflet is kind of preventing the regular wire from easily crossing it. Even though we seem to have a good direction, but still it doesn't want to go through. So now we have a Terumo wire, which is a bit more slippery wire, and we can maybe hope that this will find its way down a bit easier. It's not much we can do, of course. It's basically it's a catheter choice. Then once we have a catheter, it's there we go. So you see, this is exactly the spot, but like more slippery wire could actually slip across. It's not standard for us to use the Terumo wire. We reserve it for those cases when we have difficulty crossing, but standard would be just a regular straight tipped wire. And now you see even the catheter struggles a bit. It may shoot forward, but I'm slowly trying to use some rotational maneuvers to get that catheter very carefully inside. And it's coming now. It's coming. It's most likely sufficiently in right now. Okay, so I pull back. That's okay. We take next step in our case is exchange wire, like we call it. It's a long J wire, basically long J-tip wire, which we will use. So Ronnie, walk this out for me. We will use this to deliver a pigtail catheter, which we like to have there for positioning of the big sheet. In terms of sheet, of course, when we do TAVIs, especially with Evolut valve, we can either go sheathless, or we can still use some kind of sheath for the valve, to cross. And one of the combinations that we kind of like to use is the iSleeve from Boston Scientific. It's an expandable sheet which has a 14 French insertion profile. I believe it's 20 French at the base, but insertion profile is 14 French, and itself is expandable as valves cross it, and it's easily compatible with Evolut Pro Plus models, as well as Evolut R, even 34 in size. We have some, you can see we have some tortuosity. You can see how the pigtail is finding its way up. So, but it's going up. It's straightening now. We will cross the valve carefully. I believe the wire goes nicely in the apex, doesn't it? So we will just follow the wire. Sometimes if we would doubt wire position, we could try to pull the wire back when the pigtail is still in the upper LVOT. Yeah, I see that. See that? There's some arrhythmia that we are causing, but I think let's check now the pigtail position from some other angles. We will just move a little bit towards LAO. Yeah, it looks okay. Looks okay. It seems to be in the apical position. That's okay. So we're happy. We can pull back the wire. We will take a pressure set. We will check ACT. So let me do it. This may be easier. I can aspirate here. So we're checking ACT because, of course, it's very important both for our gear in the left ventricle, but also we have a sentinel device in the neck vessels. So we want, of course, the ACT to be in the therapeutic range of 250 or more to avoid any kind of thrombotic complications. Now, next we do hemodynamics. As we know from the workup pre-TAVI that on echo is a high gradients. We find the same actually invasively. Let's measure. It's a high gradient we can see on our hemodynamic screen. Peak gradient 60, mean 46. We have end diastolic pressure in the ventricle 17 and diastolic in aorta 58, 1758. We will remember those numbers to compare to the situation after the valve is delivered. It helps us to judge the amount of paravalvular leaks, because remember, patient is in local anesthesia. We have no option of transesophageal echo, and we trust and we rely on angiography and hemodynamics. We can do bedside echo, of course, if we have to, but that's not standard. We typically make our decision on angiography and hemodynamics, and the patient gets gets the proper ultrasound examination the day after. So wire is positioned. This is a Safari. Is it small? This is a Safari small wire, pre-shaped wire from Boston Scientific, which sits now in the left ventricular cavity. Du kan fortælle lidt, det kommer lidt større rør nu. Nej, det er bare, at hun skal forvente, hun mærker lidt. So, wet gauze. So, I just discussed a little bit with a nurse. We inform the patient that a bigger sheet is coming in, because remember, our patient is in full local anesthesia. There's no sedation. So, it's important for these patients to know what's happening, because it's not unusual that despite our local anesthesia, there's still some remaining sensitivity in the groin, and especially as the bigger sheet is crossing the vasculature. It's not unusual for the patients to experience some discomfort. So Ronnie, you keep watching the wire. So we do it very careful here. I'm not forcing my way. Ronnie is railing the wire. Let's gentle railing, and you can see it finds its way the sheath pretty easily. There's no problem. ACT? Okay, so ACT is nearly therapeutic. It's nearly 240. We can maybe add 2,000 more. Nej, det er fint. So ACT was just under 240, so we add a little bit of heparin to push it towards the other side of 250. We have a sheath inside, the big sheath inside of the patient. We have stiff wire in the ventricle. I have the wire running. So now the next step will be balloon, pre-dilatation, and then the valve. May I have another pressure set? Yeah. So I use this pressure set here to flush the big sheath. Now, balloon-wise, of course, there are different ways how to size the pre-dilatation balloon. One of the most common ways would be to look at the minimum diameter of aortic valve on your pre-TAVI CT scan, and more or less take a similar balloon to that diameter. Another thing, especially with Evolut valve, is you can ask yourself, what's the biggest balloon you can use for this particular Evolut? So here we're using Evolut 34, and the biggest balloon that you can use to post-dilate this valve is actually 24 due to the design. And 24 fits pretty good for us to pre-dilate this valve also. So we intend to use the same balloon to pre-dilate, and we will, if necessary, also use the same balloon to post-dilate, because it's then we kind of we can save a bit of our equipment. It's not easy these days to get balloons. Sometimes the delivery chains are a bit compromised. So this actually, with Evolut, this helps pretty much, because it's nice fit for pre-dilatation and post-dilatation. So again, we explain to the patient that there will be a rapid heart rhythm. We have here two pacing leads connected, one to the LV wire, the Safari wire in the left ventricle, and the other lead is connected to the wire in the vein, in the left femoral vein. And we will do rapid pacing with maximum output, frequency 180. So are we ready there? Pace on. So we have good capture. Balloon up and balloon down, and pace off. Observe for AV block. Flora safe. Okay, good. She is in the same rhythm. We walk carefully our balloon out. I can zoom out here, wait a minute, like this. We will preserve this balloon because we may need it to be used by the end of the procedure to post-dilate as well. So we will flush it and wash it. Come to the valve. I hold the wire. I hold the wire. Now I'm not holding the wire, careful. Okay, good. I'm holding the wire again. So now we get the valve, and you will see this valve will cross the eye sleeve. So remember, eye sleeve is like 14 French insertion profile. It should match pretty well the even 34 Evolut R. Let's connect some flush here. Just reflush just in case. A bit forward and close it now. Now somebody should be watching the wire. You watch, guys, yeah? Okay. So I will go slightly lower. So we still keep wire in the picture, and we include a little bit of the sheath in the that you can see, you know, how that valve is traversing and crossing inside the sheath. So watch the wire. I'm going forward, and it goes pretty easy actually. You know, it's not, sometimes depending on the specific sheath, you may expect a bit more resistance, but here I basically just use a couple of my fingers actually to push it forward, but sometimes it's much more difficult than that. So here we have like a nice match between the two devices. So we're out of the sheath. I will connect my pressure set here to the inline sheath now. Next thing we'll do, Ronnie is already moving the table towards LAO direction, because with Evolut, it is of course important to make sure that we have a marker, so-called head marker, on the outer curve of aortic arch. And to see that, we need to go LAO. So this is LAO direction, and we will want to see the head marker on that outer curve. To achieve that, we typically have a flush port of the Evolut valve facing 3 o'clock. Usually that helps, but sometimes you need still to fine-tune it a bit as you come up. So Ronnie is watching the wire, and I believe we see the head marker nicely on the outer curve. Agree? Yeah, so it's nicely on the outer curve at the front end of the valve. Now, remember, the arch is a little bit on acute side, not very acute, but a little bit on acute side. So Ronnie will be railing, like pulling back on the wire, maintaining tension in that wire, and we are carefully crossing forward. You see there's no interaction with the Sentinel device in the neck vessels. Sentinel sits nicely inside of those vessels and doesn't interfere with valve crossing. So it's all good here, nice crossing. Flora, save that. And now when it comes to valve positioning, we have noradrenaline ready just in case. Just let's connect that. Hemodynamics is stable, but we sometimes just connect just in case. We can connect to the venous system. We can connect, like fluid infusion and potential for noradrenaline should we need it. We also connect pacing lead to the stiff wire again, because as we deploy Evolut, we will want some pacing. And in terms of optimal projection, we again go to the cusp overlap projection, where on the right of the screen we have we have systolic pressure 80. So let's start noradrenaline, go on 10. Just to keep it in a more stable situation so it doesn't drop further. We are of course occluding the valve a little bit with the nose. So maybe we will have to move so that the pressure doesn't fall further. Let me see if we need to reposition the pigtail a little bit because it's wrapped around a tiny bit. I probably need to go back to the descending. Come again with the pigtail. We want the pigtail to be sitting in the non-coronary cusp like that. Pressures, let me pull back, okay? Let me pull a bit back, keep the wire. So I will pull back the nose cone to let the patient breathe a bit, because we've seen a fall in pressure, probably because we're occluding a little bit of the outflow. So we started noradrenaline on a slow, gentle infusion, and now we see the blood pressures coming up. Systolic is 80, 84. So I'll wait a little to let her breathe, and then we will go forward again. And in case she drops pressure again, we may have to move quicker. That's something, some patients don't tolerate. Longer positioning. Now systolic pressure is close to 100, so all is stable. You see by just pulling the valve a bit up, we allow better outflow from the ventricle. So we have 100 systolic pressure, 106. So things have stabilized. What we will do, we will cross again. Let's enable the injector. Then we'll see if she drops pressures again, we'll have to just move a bit faster. So we go forward again, gentle railing there. So the valve is crossing. We come in, and here I will already start unsheathing. I believe pigtail sits really well based on the calcium that we see. So you see, we start to pull back the capsule early, but of course, our aim is to position the valve more or less in line with the bottom of the pigtail. That's a moment to inject. Yeah, we're pretty good there, as I see it. Pace 120. We will do some rapid pacing here, not very fast, but then initially 120. Maybe we'll increase a bit. Go 140. Keep gentle push on the wire. 160. Now she loses pressure because we're occlusive. I go faster. And stop pacing. Stop pacing. Observe for AV block. Let's see. What do we have? No AV block. Actually, she has own rhythm. Let's assess now the situation. Where are we? So we try to go out of a parallax. We don't want to have any parallax on the valve at the time of assessment. So let's see here. Yeah, the patient is, remember, full local anesthesia, so we communicate. Birgit, our nurse, helps with that at the moment. She tells the patient what's happening, that it's the valve which is being placed. Nej, ikke lige nu, eller måske, ja, 15, yeah, let's do that. Okay, so let's check the position here. There's quite a bit of leak that we see, actually, and that's the reason the pressures are not very high. So we may need to move faster, and we need to make a decision. Are we happy or are we not happy? Let's check it from here. Not too bad. I would say play back on the minus. So having in mind potential need to post-dilate, we probably are not bad. We're pretty high on the non-side. Maybe I'll do one more projection from here just to have a little bit better understanding about the non-coronary side. Like this one here. So basically what we're trying to do is do we want to reposition or not? So, well, this is, I think, according to the book, we are like 1 millimeter below the pigtail into the non-coronary side. Play back on the minus. We seem to be in the middle of aorta, kind of. We can expect a little bit of diving on the non-side. And my thoughts were, do we need to go higher? But on the other hand, on the left, we are not very deep there. So and the STJ is not very wide, so it should hold the valve and prevent it from deep diving. So probably we will accept. The patient is stable, actually. She's noradrenaline did its job. Its pressures on 95 or so, systolic. Play back on the minus again, two times, 1 and 2. What was it? LAO 48. So we go to the LAO projection and a bit of a caudal. We will double check from here. I'm leaning towards accepting this. I mean, we can see the patient doesn't tolerate all the manipulations too well. I think we're in a reasonably good position. We could maybe go 1 millimeter higher, and now we risk it may slip a little bit down on the non-side. Otherwise, I'm pretty happy. So let's accept. Let's go down on noradrenaline to 5 and relax the wire now. Relax the wire, and we go for slow deployment. We go for slow deployment, and we're gonna see how that valve does. It's very slow deployment that I'm doing. Relax it like this, yeah. It's very slow deployment that I'm doing. It's important to take your time here, because it usually ensures more stability. So we're almost fully out. There we go. It's released. I don't think the valve moved. So it seems to have stayed stable. Flora, save that. Do 5-5 for me, 5-5. Stop noradrenaline completely. So as you can see, we don't even need to inject at all. We can see based on how the valve looks in relation to the pigtail, we'd stayed completely stable, the valve. It didn't move. So the judgment was okay. Pressure is back. Let's now remove the system, and let's think whether or not we need any kind of post-dill. There was some leak. And we know that's severely calcified anatomy. Now we have a little bit of an issue with the wire here because it's not in the apex, but keep the wire, don't lose the wire, okay? Keep some forward push on it. Keep forward push. I hold the wire, yeah? Yeah, stop it helt. Wire full standing. Okay, wire came in nicely, just gently pushed on it. So we have wire back in position. What we will do next, we have two options. We can either check the result, do angiography, and then decide about the need for post-dill. But on the other hand, we saw some leak, and I want to save contrast here because renal function is a little bit impaired. It's a safe and secure valve position, so I would use the same balloon we used to pre-dilate. I would also use it to post-dilate, and we know we did everything we can, and there's not much else to be added because 24 millimeter balloon was the biggest balloon we could use, and that's exactly what we're going to do. We will post-dilate with the same 24 balloon, and then we'll check the final result, and then we do angiography. We measure pressures, and hopefully all is good. Before we post, by the way, we need to remove the jailed pigtail because we left the jailed pigtail behind the calcified cusp there, so we shouldn't post-dilate, with the pigtail jailed. Some negative, it's negative, yeah? Watch the wire. You watch the wire, yeah? So I will stop above the valve, pull back a bit on the wire so there's a bit deepish with the slightly irritation on the ventricle. Pull a bit gently back. A bit more back, like this. All right, we stop there with the balloon just above. Now we take like a regular wire. Jailing the pigtail behind the valve usually is not a problem. You don't have to do it, but like the nice thing by jailing is that you have very good possibility to assess your real depth. Because the pigtail is usually stays in place. It's also possible to make such a minimal contrast injection if one would want that. I don't think we need that here because we see it so well, also the calcium of this non-coronary cusp. And to unjail the pigtail, you typically just put forward the regular J-wire, keep it there, and then you pull back the pigtail, and then afterwards you gently pull back the wires, as you could see we have just done. Wire back. Next, we'll maybe I will do pressure set here first. We will measure pressures. After we post-dilate, we will do hemodynamic assessment, and afterwards we will do the angiography. Okay, good. So next, now we will cross the valve. We will pace again on the wire. We will do 220 pacing with a maximum output. That will be our intention and plan, like that. We need to remember to connect again. We are connected. Our leads, our pacing leads are connected. So Ronnie, you ready to go up? Let me see. I'll gently push on the wire gently, like this. This is actually good. So pacemaker ready. Pacemaker on. Let's see if there's good capture. No capture yet. Let's wait. Sometimes it comes just a few seconds later. If not, we will go slightly slower on pace rate. So in that case, yeah, now we have capture. Wait. Okay, go up. Go up all the way like this and down. And pace, and stop pacing. Fluoro save. Observe for AV block. No AV block. Okay. So we saw the valve frame a little bit expanded. So this balloon did a little bit of additional push on the frame. And actually, we cannot do much more. We chose the biggest possible valve. I believe the valve sits very correctly in terms of height. And now we use maximum possible balloon to post-dilate. So in case we would still see some remaining PVL, hopefully not, but if there was a case, there's not much else we can do about it. Because we cannot normally take a bigger balloon. There shouldn't be any need for that, but we'll see. So our next step, we're putting pigtail into the LV. We will first do hemodynamic assessment, and then we'll do angiography. Then we'll see what those things, what information do we get out of it. So pigtail, it comes down. Yeah, wire back. So we'll do first hemodynamic assessment here. So we have one pigtail sitting in LV, the other pigtail sitting in the ascending aorta. And we're going to see what pressures can we measure in those places. So pressures are on the screen. So gradient is 0. There's no gradient that's obvious from what we see. Our previous pressures were 17 in LV, 58 in aorta. We have 24 in LV, 50 in aorta. So the separation is slightly smaller than it was before the TAVI. Gradient is only 2 millimeters invasively, so there's no gradient. Except that, we can do one more run just to see if anything changed while we were just standing here. Measure there. Yeah, indeed, something very similar. 2 millimeters gradient, except that too. So we'll do an injection. Let's put the contrast on, gentle forward, and 25 in total, 10 per second. We put it there. Okay, here we go with a contrast injection. Okay, there's a little bit of leak that we see actually. Yet again, can we do anything about it? Valve position is really good. There's no doubt that it's sitting properly. It's probably 1 or 2 millimeters below the bottom. No more than 2 millimeters certainly, maybe just 1 millimeter below the bottom of the non-coronary cusp. We did a post-dill. Can you go back on the post-dill image? So I'm happy we did the post-dill because otherwise we would have, it would, so let me, like let's, we go back and forward again and let's do it here. Let's review once this post-dill. There we go. So that's a post-dilatation on the screen that we see. Let's see what happened. So balloon is correctly in place and it was maximally inflated. There was some recoil. Of course, we know it's severely calcified valve. So probably there's not much else we can add. We can do one more injection from LAO. Let's see what that shows us. Maybe it's LAO 40 we should go. Let's do our assessment here. This also to judge both the depth of it and the amount of leak and to have a full understanding. We enable them. Okay, here we go. Oh yeah, so we see a little bit of leak next to the valve. That could actually be also partially due to the fact that anatomy is really large. This was the upper limit for everything, including Evolut valve. That was, we measured perimeters approaching 94. So in that case, of course, it could also be close to the limit of what the valve can cover. Otherwise, the position of the valve is really as it should be. It's in relation to the left bottom of the left cusp. I think we may be 3 millimeters below the annulus or so. In relation to the right cusp, we are the non-coronary cusp. We're just 1 or 2, so it's symmetrical. It's not too deep. It's not too high. I think we will accept this result at the moment because additional things that one could consider, if the leak is too much, it would probably be a valve-in-valve to extend the seal higher up, but that should only be considered if the valve is if the leak is really giving symptoms and more than moderate in severity, or at least moderate in severity and giving symptoms. Here, at this very moment, I would qualify this as a mild leak. You could discuss mild plus, like between mild and moderate. It's a bit more than we typically want to see, to be honest. But again, you typically can ask yourself 3 questions each time you see a leak. Is the valve size correctly chosen? So this is the biggest model we could choose, Evolut 34. Then is the valve position correct? And looking at these angios, I don't think you can do a better position. It's exactly how it should be positioned, 1 to 3 millimeters below the annulus. depending on which cusp we look at. And then the third question is, did we use a biggest possible balloon? So we used a 24 balloon, is that correct? That was a 24 balloon, which gave some expansion and then some recoil. So in this situation, I think we will accept this leak at the moment. We will follow the patient clinically, and only if she has a problem, we will then consider something additional. She is 83, so normally longevity-wise, this should not have any impact. And if she doesn't have any symptoms of it, then we will be happy. If she has symptoms, we will bring her back and do some additional things with the valve. But as for the moment, we will accept it, and we will not proceed with any additional interventions at this time. Good. So then next thing is going to be removal of equipment from the patient body. And first of all, we're going to remove the LV pigtail. We will keep a stiff wire in the descending aorta. So that's our stiff wire in the descending aorta. We will also remove a pigtail from which was introduced from the left groin. And we will also remove a sentinel as a next step, because we're done at the heart level. We did not do any additional. We will not do any additional manipulations there. And also from here, the shape is fine. Look, it's like AP caudal, so the shape of the valve seems to be very good. It's of course a lot of calcium there, so it's a bit constrained maybe, but okay, that's a limitation of the technology as I see it. Now, when it comes to the sentinel, so we first unlock the handle and we pull back the distal filter, as you see being done right now. Then we push forward the whole system, unflex it, and then finally lock or sheath in the proximal filter like this. So then both filters are captured and the system is removed from the body. At this time, we can give some protamine because we are going to be closing the groin. So Ronnie, we can switch here. So maybe, hvor meget var det i alt? Heparin? 10.000, så måske 4 protaminsulfat. So we will give like 40 milligram protamine sulfate to revert any remaining heparin. And now next thing we'll do, we'll take a dilator for the big sheath, for the eye sleeve. Yeah. Yeah. So we used like 100 cc's of contrast. As of right now, we will still use like a 5 or so to check the groin when we close this. And now when it comes to groin closure, so we keep the stiff wire in the proximal descending aorta. We remember we have one prostyle in the groin. And Ronnie is now putting the knot pusher on the prostyle, one of the sutures, pulling back our big sheath. Next thing we'll do, we'll take a 9 French sheath back in. Also, Berge, du kan fortælle måske lidt. We also explain at vi lukker lusken. We also explain for the patient that we're closing the groin because sometimes it brings a little bit discomfort there in the groin. And remember, again, patient is in complete local anesthesia. There's no sedation. She's 83, so she needs to know what's happening. Now we come with a 8 or 9 French sheet. And now let's see what the result is. Ronnie, if you come back with your pusher, we want to assess. Is there any remaining bleeding. So 9 French sheath doesn't have any bleeding next to it. So we're pretty happy with that. We will connect gentle forward. Thank you. And don't push on the wire, because otherwise let's centralize that wire like this. So what we will do, just a minimal, such a 5 cc injection in the femoral artery, just to check is all good. Do we have any dissections or any major stenotic lesions after our procedure? So that's what we're doing right now. We will do this injection using this 9 or 8 French sheath inside of patient's right femoral artery. Yeah, so it's a nice flow. There's no problem. There's no dissection. There's no bleeding. There's a nice flow down. So we're pretty happy with the result. No external bleeding. So next we will finish, as I was trying to suggest in the beginning of the procedure, we will finish with an angioseal. We will remove this 8 or 9 French sheet and we put angioseal 8 French instead. And again, we use this combination of suture-based and plug-based device. It's our preferred combination at this time. So angioseal comes in, we document back bleed, we take a plug, and then once angioseal is deployed, we're also going to use a metal instrument, a clamp here, to fix the pusher of the angioseal in position. And now let's see if we have any remaining issues. So the groin, if we clean up, seems to be completely dry. There's no even a drop of blood there, so it's a very effective and reliable closure. When it comes for the other groin, on the left side, so we will start with ProStyle, just one ProStyle, and usually that's enough. In case there would be any issue or concern, we can always supplement with an angioseal as well, but it's normally not needed because it's only 8 French sheath, which is currently inside of the left common femoral artery. So normally just one ProStyle would be enough. So unless it fails, we don't really expect anything other than this one ProStyle. But nice thing about the ProStyle that if it would fail, if it would be insufficient, we will not be losing any access, and we can supplement if we have to with an angioseal. That we do in small percentage of cases if needed, and then have again a very reliable combination of the two closure techniques in those cases where it's necessary. Okay, keep it a bit steeper maybe. I like this. Yeah. Yeah, so it's a good catch. We have a, it looks like the ProStyle captured sharp, careful. Yeah, I hold this. You take the short suture here only, and this is not pusher. So what we do next, we put a wire inside of the ProStyle. Ronnie will get ready to push the nut down, and we remove the ProStyle. Ronnie pushes the nut down. It's important to remember to make a small cut in the skin. Not a big one, just a small one, but if you forget to make a cut, sometimes this knot pusher is difficult to go down. So let's see, what do we think? It's a small losing, but are we concerned, or do we say this is good? This is probably going to be fine, I am pretty sure. Oh, what? You're not happy? Maybe a bit more than we ideally would want to see. So, okay, let's add 6 French angioseal, okay? This is, normally it's not needed, but here, of course, this would come away, this would go away with some manual compression, certainly. But if we want, you see, on the big side, there's not even a drop of blood, so if you want to stop that small losing, you know, we can add an angioseal, and then we have normally a very reliable combination of the two. So let's do that, and we don't need to worry, and we don't need to stand there compressing. Oh yeah, I know what's, so this is like that, a bit thicker wire. Yeah, yeah, good. Gentle rotation, just gentle rotation. Yeah, and yeah. Yeah. Yeah, that's okay. Oh, careful. And the clamp. Yeah. Yeah. So we clamp the other one in place. And now if we look at the closure side, it's again immediately completely dry. So this additional angioseal was probably not necessary fully. It would have stopped with some manual compression, but now we don't have to compress. It's kind of very easy addition, which gives immediate result. Well, I believe the case is finished. So I can come up here closer to the camera. And not sure if you see me or not, but like I can just thank everyone for joining, everyone who was watching. I hope the case was educational and useful. What we saw was Evolut R 34 millimeter valve in a big anatomy, a big calcified anatomy, deployed in a proper position. We ended up with more than mild, probably PVL, or mild plus PVL. Which is probably due to the big anatomy combined with severe calcification. One could speculate if Evolut Pro Plus 34 would have been a choice which would have delivered maybe a slightly better result, but on the other hand, then you need a much bigger French size, puncture hole in the groin, which is to us a bit of a concern sometimes, is for this patient especially. That was the reason we chose Evolut R. Otherwise, you saw closure technique, you saw the procedure techniques we use, wire pacing on the LV, you saw the combination of ProStyle and Angio in the groin. And for the rest, I believe we have a nice rhythm remaining. There's no pacemaker, there's no bleeding in the groin, there are no other complications. So kind of a nice case, except for slightly more than usual in terms of PVL. So from here, I will say goodbye. Thank you again for joining. Thanks to the team for making this case happen. And see you next time.